Well, hi, everybody. My name is Garrett Schmidt, and I am the managing editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar slash fireside chat with Credo. And we have an exciting session today, and it's called Clinical Blind Spots, Solving for What's Around the Corner in Value-Based Care. And obviously, I know this is a very important topic to all of us, and so excited to hear from our speakers today, who I'll introduce in just a moment. A few items of note before we get started. This is a traditional webinar format, so everyone has joined today in listen-only mode. So you don't need to worry about turning off your camera or your microphones. We can't see you or hear you. But we are going to have a time for some Q&A towards the end of the session, and we would love to hear your questions if you would like to ask either of our speakers. So if you'd like to do that at any time during the presentation, you can use your speaker module to ask a question there. And there's a place, or your attendee module rather, there's a place for questions specifically. So go ahead and drop that in there. And we're going to get to as many as we can during the allotted time. We have an hour for today's session, but we may end up ending early. We'll see. And a lot of that will depend on the questions that we have. But if for some reason we don't get to yours, don't worry, someone will actually reach out to you via email to make sure that we get your question answered. And also what's going to happen today is about an hour afterwards, you're going to receive an email from one of us, and there'll be a link to the recording as well as to where you can download the slide. We don't have a lot of slides today, but we got a couple things with some links for you, and you'll be able to download those slides as well. So without further ado, wanted to introduce our speakers today. First of all, we have with us Mr. Brigham Hamlin, and he is the Chief Commercial Officer with Credo. And then we have Mr. Logan Steele, and he is the Chief Operating Officer with PCC Medical Holdings. And they will be our guides today. So welcome, gentlemen.
I appreciate it, Garrett. Yeah, so really appreciate everybody joining today. I'm excited for what's going to ensue over the next hour. I liken it to all my conversations with Logan in recent months, which is me picking his brain on some critical topics here in value-based care and getting a better understanding of the landscape from one of the premier and most innovative operators in the space. So really excited about that. Want to do a quick introduction of myself. As it was noted, I lead the commercial team here at Credo. I've been in healthcare for the better part of 20 plus years. Started on the life sciences side at the bench in Palo Alto, California. Went out to build out the health systems team at an organization called Council in the women's health space. And then most recently spent 5 years as the CRO over at a company called Vim in the middleware space. So excited to be here with you. A little bit about Credo. Our platform leverages the most comprehensive set of patient-specific clinical data to deliver evidence-rich insights on patient health. And we do a lot of things with those core competencies and excited to partner with anybody in the future as we go there. A quick introduction, Logan, I'll let you talk a little bit about yourself and about physician care centers, where you find yourself.
Yeah, absolutely. And I appreciate the kind words, Brigham. My name is Logan Steele. I'm the current Chief Operating Officer of a at-risk primary care group called Physician Care Centers. We are family-owned and operated. We got started, I think, late 2015. I've been with the business since 2018 as kind of the first or second corporate hire. Effectively, we run a multi-state risk-bearing primary care platform that operates both a kind of staffed model as well as an affiliate, and kind of support all of our PCPs through back office, technology, analytics, and some more kind of billing and coding exercises as well. We also provide kind of wraparound services from a care management, transition of care perspective as well. We got started in Georgia, which is, I think, kind of a unique perspective. Our CEO, who also happens to be my father, he worked at Humana for about 20 years. And came over to the provider side in 2012, and had a small MSO in South Florida. And when we started this business in Georgia, it was a very quick, I think, shock. I think there was a lot that we found to be misunderstood about value-based care outside of Florida. So it was a relatively large learning curve for both us and for our provider partners. But I think what we've been able to do is take those learnings from kind of a non-sophisticated value-based care market, figure out what really needs to happen to transition practices to value, and then transform practices outside of the state of Florida, moving into Texas, Nevada, and South Carolina with those learnings that we gained early on in the creation of the business.
Yeah, appreciate it, Logan. So how many providers?
I think currently we're just under 150 providers.
Across how many locations?
Geez, I think we're up to about 100 or 95. It's dynamic. It's constantly evolving. High growth organization.
That's great. I appreciate the context there. So Logan and I are going to have a fireside chat here about some of the topics that we find really interesting in the space. I live in the Northeast out of Connecticut, and it finally has cooled down enough to do a fireside chat here, although we don't have one on the screen. So excited to spend the time with you. So maybe Logan, we kick it off. Sound good?
Sounds like a plan.
Awesome. So we'll start really high level here. It's been a ton of changes the last few years in VBC and MA specifically. You highlight a couple of the most impactful and talk about how your organizations and others around you have had to adjust.
Yeah, absolutely. I think when you look at kind of the regulatory landscape, there's obviously been two massive and notable changes in kind of the recent years, which is the shift to V28 and the Inflation Reduction Act and how it's kind of redesigned Part D as a whole. I think from a V28 perspective, and I'm sure everyone here is familiar with what happened there, but effectively, right, several thousand of the most prevalent HCC conditions were removed from the HCC model, which drastically reduced kind of total funding as it's associated with MA in general. I think there's been a couple downstream effects of that. Obviously, there's been a lot of risk-bearing entities that have not managed cost as well as they should have and focused on risk adjustment, which I think they're going to experience the downstream effects of that into 2026. But it also reduced total benefits for our Medicare Advantage eligibles. I think we've seen the prevalence or the penetration of MA, surpass 50% as a total of the total MA or Medicare population. I always wonder because of that that change if we see a slowing to that MA penetration rate. But I think from a total funding perspective, obviously there are headwinds. I think if you have a really robust kind of care management and cost management program, you should be just fine. From a Part D perspective, the Inflation Reduction Act did quite a bit. I think it gave Medicare the ability to negotiate drug costs associated with some of the more cost-driving medications, but it also shifted plan liability from about 15% to about 70%. So reinsurance is not going away, but it's dramatically decreasing. So I think in my perspective, there hasn't historically been a massive incentive to reduce total spending as it relates to the Part D benefit. I think that now changes. It has to be kind of one of those things at the forefront. As you're generating referrals to your downstream specialists, I think prescribing becomes a big role as a part of the entire cost structure.
You mentioned, Logan, that some organizations were better positioned for the changes that you just noted. What are some of the things that PCC did in particular to get ahead of let's just say V28?
Yeah, so I think it comes down to market dynamics. You have to really pay attention to the plan partners that are aligned, right? There's some plans in the market that don't share the same kind of philosophies as us in terms of benefit design and things like that. So I think it's really important to make sure you have a plan partner that supports you. Two, I think you're not going to be able to outcode this, and I think that's been like a predominant theme in some areas. I think what has to happen is you have to shift to a super robust care management tactic. and really get to the bottom of what's driving cost. I think for us at PCC, I think coding intensity has never been at the forefront. I think we've always had a really heavy focus on cost management and care management as a whole. So I think what we've done is invested significant dollars into additional, care navigators, care coordinators, social workers to ultimately build out a better and more superior clinical model. And we also intend on growing out of some of these changes as well through just onboarding additional providers and locations that we feel we can better manage.
That's so really appropriate sort of transition into the next topic I wanted to go a little deeper on, which is the health improvements quadruple aim. When we think about utilization and clinician experience, enhance the patient experience, reduce medical costs, improve health outcomes, and improve clinician experience. I'd love to start with the latter, the clinician experience. What are some of the things that PCC is doing to ensure clinicians remain at the center, the North Star of your care model?
Yeah, absolutely. And I don't think that really never ends. And I think it's because historically, and what we've seen is medicine's become so burdensome. And like I think there's some statistics out there for every one clinician, there's like 10 administrators. So I think there's a lot of administrative work that has to go into ultimately just seeing patients. So what we've tried to do as an MSO and as a group is take as many of those administrative back office things away, and to ultimately help support our providers. I think at the end of the day, providers love treating members and they love treating patients and seeing positive outcomes. So what we've tried to do is build a model that allows them to do that. I also think provider leadership within an organization is extremely important. It's not helpful when guys like me without any kind of clinical pedigree try to get involved with clinical decision making. So we've built regional medical leadership as well as medical committees. And we let them kind of make all the decisions from a clinical and medical guideline perspective, which I think one allows them to make their own decisions as they're treating their members, but also it keeps us it keeps us informed into ultimately what their decisions are. But I never want to be into the practice of ultimately changing clinical guidelines because that's just not what my specialty is.
Yeah, it's really interesting. You mentioned the regional committees for providers. I've always heard that medicine is very local. And so have you seen a pretty significant variability in the priorities and preferences of practitioners in one of the states that you manage care in another, or maybe even city to city?
I think there's always going to be nuances as it comes down to particular patients, but as we think of kind of pop health, I think generally there's a lot that's similar, right? Across the population, what are the things that we want? We want to keep our patients out of the hospital. We want to make sure our patients are taking their medications, and we want to make sure that patient out of pocket costs are as low as possible. And I think our medical committee helps guide our decision making as we try to make sure that our members and our patients stay at the focus and at the center of all of our decisions. So yes, absolutely. I think it's, medicine is extremely localized. There's a lot of nuances, but I think generally everyone's definitely swimming in the same direction in terms of what the end goal is.
And these investments that you've talked about, have you seen them deliver outsized improved health outcomes in comparison to your peers or other publicly stated data?
Yeah, absolutely. I think we've seen it just in patient satisfaction, right? Just our retention of our members has grown significantly since we've adopted a more provider-centric model and patient-centric model. So I think the retention of our members speak for themselves. Obviously, there's decrease in admits per thousand, decrease in readmissions, which are more the clinical KPIs. But absolutely, I would say that the investment has materially paid off.
Utilization, and this is sort of an extension of that, utilization has been front and center this year and really the last 18 months as providers have seen medical costs exceed expectations. Broadly speaking, what do you think the biggest contributing factors are to this?
I think there's a couple things. I think in this kind of post-COVID era, we're always experiencing some level of like COVID shock, I would say. I think we saw record, lows in terms of utilization back in 21, and I think there's still some lagging effects. in terms of um, delayed knee replacements and things of that nature. Uh, I have seen, and I think from some of the large payer public reportings, there's been a spike or a prolonged increase of just general admissions. I think, you know, to get to the bottom of that, I think is a super nuanced conversation. I think there's several and a lot of factors that go into that. And then you also look at kind of the pipeline of available treatments that have come to market, right? There's so many new drugs, there's so many new injectables um, that are constantly coming out on a day-to-day basis, and I think there's probably five or six main drivers that are driving that ultimate utilization. But I would say in terms of total cost and inpatients, I think a lot of it still has to do with COVID, unfortunately.
And do you see that tailing off, those headwinds sort of diluting over the next 18 to 24 months, or do you think it's a consideration that teams like yours will have to contemplate on a go-forward basis?
I think the jury's still out. I think what we can do is just develop really robust care pathways and care programs for opportunities that we know we can address. But I mean, I think population level healthcare is extremely dynamic and extremely fluid. So as things arise, we try to get our arms around it and address it from a pop health perspective. But I think it's tough to say at this point.
Yeah, I like the point. The jury's still out. We'll see where it goes. TEFCA's been in the news recently with both Epic and Cerner and others committing to contributions to that data access. Access to patients' medical history has broad impact in value-based care. I'd like to focus on two areas there and how PCC thinks about this. What do you think the benefits to your care model are on existing patients first, and then what are the benefits to net new patients that come into a practice given this broader interoperability play that's in the market?
Yeah, absolutely. I think when we look at existing patient care and kind of the data that we receive from our colleagues in various specialties or the hospital partners that we have, I think we're only getting about 40 or 50% of the actual clinical documents back as patients leave our centers. So I think a lot of our care models and stratification models are built on disease, right? So obviously to develop a appropriate care plan for a diabetic, you need to understand that a member is actually diabetic. So I think getting more information is always helpful. It allows us to one identify conditions that are potentially driving patient acuity and mortality, which is super difficult to do without all the data, just inherently. And then two, it also allows us to understand what our population in general is experiencing and develop care plans that are specific to our population. So I think ultimately disease discovery is super important. And without the data and without the clinical documents, we're not able to fully treat the members in a way that is materially beneficial to them.
So when a patient that you guys take risk on goes outside your four walls for care, whether it was intentional or not, how do you go about acquiring that data? Do
So
you have?
yeah, I'm sorry. Typically, we rely on, the specialists or the hospitals to fax us the records. Obviously, that doesn't happen 100% of the time, so we'll request the medical records. I think with our new partnership with Credo, a lot of that legwork has gone by the wayside. We're now getting documentation that we did not receive previously from clinicians that haven't always been the easiest to work with. So from a 360 view of the patient, I think to get to 100% of all documents and in all clinical data is extremely difficult, but we've done a really good job of getting from that 30, 40, 50%, much closer to 95% in terms of a 100 or 360 view of the member.
From your experience, which is the harder problem to solve? The existing patient blind spots that you come across, or new patient blind spots? I mean, you mentioned that you guys have really good retention of members, but you're also growing, so you're getting new
Right.
members every year outside of just attrition. Like from an operator's perspective, which is the bigger challenge?
Yeah, I would say probably new patients, and it's just because the legacy way of understanding, a full view of the member is typically requesting previous PCP medical records, and then from there, you see gaps where there was maybe a referral to a cardiologist, and now you have to go request a record from the cardiologist. So it becomes kind of a 6 month to 8 month process, and that's relying and expecting that we actually get something back 100% of the time. So it becomes like a treasure hunt, and we turn into private detectives to try to track this information down. I think leveraging TEFCA has been extremely beneficial, where now with the click of a button in a couple minutes, we can get a vast majority of the entire patient's health records. And really on the first visit, instead of having to walk through these super comprehensive 10-page HRAs to figure out what the member has, and obviously we're relying on member feedback. We're able to get a really robust view of where the member's been and where they're going, which from a first patient or from a first visit perspective, extremely beneficial from a risk perspective, but also builds that relationship with the member, right? It's always tough as a member forms a bond with a new provider. And if we can come into that relationship with a pre-existing understanding of where that patient currently stands from a medication and lab and clinical and diagnosis perspective, it allows us to form that relationship much faster.
Historically, claims have played a huge role in sort of understanding that those care pathways and what a member under different risk arrangements before brings to the table. Has it changed that outlook, or will it change it in the future? Like claims remains relevant, I assume, but in conjunction with the clinical data.
Yeah, I think it's important to look at claims to understand past history from a site of visit perspective, but there's so much information that's missing from a claim, right? Typically, you'll get a data service, you'll get a diagnosis, or a handful of diagnoses, and that's really it. And what it doesn't let you see is how those diagnoses are being treated, what medications are being used, ultimately how that diagnosis was formed. So I think it's great from a general understanding to see generally where the member is, but ultimately from a new patient perspective, we don't have that claims history, right? So when a new member joins, I don't have 24 months or 36 months or however long the member's been within the health system. I don't have that kind of that clarity. So when I think about the clinical data and marrying it to the claims data, it's a much different outlook. We're able to really understand why a patient has what they have, and ultimately how it's been treated historically, and why that may or may need to change in the future.
I'm thinking, given interoperability where it is today and where it'll be tomorrow, does it give a PCP focused care model more flexibility on where their patients can seek care outside of your four walls? Does it make it actually open access and easier to manage that patient?
When you say manage that patient, are you referring to like virtual care, or is it more so like the specialty care downstream of the PCP?
I think virtual care can be one aspect of it, but I imagine in these referral chains of managing a patient from one condition to the next, you have trusted partners because you had access to the data. So there was confidence that you could close that clinical loop and provide the best care. As interoperability comes into play and you have more access to data even outside those walls, does it open up or create opportunities to remove the constraints of specialty care? I mean, you hear all the time that like 6 month waits and like having more sites of care that you can go to and still keep that care model connected. Is that a benefit in general, not to PCC specifically, but in general to managing patients through all the different conditions that you have to manage?
Well, I think it definitely does help us manage, all, and we have a very polychronic geriatric population at PCC, and it definitely has helped us manage. I think you're always going to want to have partners that treat your members right, and a 6 to 8 month wait time is in my perspective not treating our members right. So you're always going to want to have relationships with partners that work with you, not only from seeing your members and treating with respect, but also collaborating on treatment plans. So I think absolutely. I mean, as we look at the network that we've created from a specialty perspective, the first thing that we look at is not cost, right? It's the quality, it's the outcomes associated with that specialist. Um, One of those big driving factors is how they collaborate with our PCPs as they form, these robust care plans. So I think in terms of looking at downstream referrals, to me, not much has changed, but it has allowed us to collaborate more efficiently and more rapidly with our specialty partners in the market.
Do you see more subcapitation, more specialty organizations coming in to support that quality of care that you guys are really optimizing for?
Yeah, I think we've seen a couple interesting models come to the market. Um, I think there's I put them kind of in two buckets. There's virtual first specialists that I think are beneficial to an extent, but I really like the models that sit on top of specialty networks that help with the coordination of care and ultimately drive better outcomes. Not necessarily from a provider group perspective, but almost from a specialty MSO perspective. So I do think that there's going to be a lot of value in that. Ultimately, additional eyes on our patients is never a bad thing.
And more specialized eyes.
Yes, exactly.
Yeah.
Exactly.
I mean, I feel like the trend in healthcare in general and in value-based care, maybe more recently, is that the multi-specialty practices where you can cover a patient from start to end because of A, the care coordination, B, the convenience factor of that. But seeing so many new organizations coming in, hyper-focused on aspects of care, even within a specialty, I'm just curious if there's going to be more consolidation of those into a single care model in single risk arrangement, or there'll be further proliferation of hyper specialization in the space.
You know, I I think I think it really depends on the market. Like there's so many different nuances. And I think we have seen the consolidation in some areas, right, where there's a large hospital-owned specialty network, and that's really the only specialty network in town. Or you look at like an area like New Jersey, where there's a lot of independent specialists that still operate. I do think there is value in like limiting variability. Knowing that a member going to cardiologist A versus B, they're going to receive the same care. So I do like the concept of kind of these wraparound services built on top of particular specialties, because ultimately, regardless of where the member goes, they're going to get the same outcomes and the same kind of care plans and treatments, obviously dependent on the member, of course. Um, but I do see it kind of decreasing the variability associated with, from specialist to specialist within the same specialty.
Yeah, that makes sense. Yeah, the strong will survive
Yeah.
in that model. So the best at taking care of those patients, reducing utilization, and driving quality outcomes are going to be the winners in the space. Yeah, super interesting. Um, as you think ahead over the next 18 to 24 months, what do you think the headlines in value-based care are going to be? As you noted before, Part D, A28, these are the things we've been hearing a ton about most recently. How's that narrative going to change over the next 2 years?
Jeez. I personally believe there's going to be a consolidation. I think one, the strong will survive. And I think the ones that don't make it will be consolidated underneath these large payvider organizations, or these large like national MSOs, which I think is kind of, it's like a disservice a little bit to the ecosystem. I'm not saying that more is better, but I do like the fact that independent providers that are incentivized to stay independent. I do think there's value there. But I do believe there will be significant consolidation in the market in the next 18, 24 months. I think that'll be probably the biggest headline, where you see some of these larger MSOs either consolidate into other organizations, or ultimately dissipate because of a lack of performance.
And do you see payers, as an example, increasing their delegation downstream to these organizations? Do you see more MA members, going to full risk under an organization like yours over time?
Yeah, I think it makes sense. And to your point earlier, right? healthcare is extremely localized. I mean, obviously there's pop health aspects, but ultimately it's the folks that have the boots on the ground that really know what's best for the members, the PCPs that are on the ground. I do think, and I think the numbers can show for themselves that delegation, it works from an outcome perspective. I think from an economic model, it also makes sense, right, to shed some of the risk associated with membership. And ultimately, health plans are not in the business of managing patients, right? They're in the business of managing risk. And I think one of the better solutions to managing risk is delegating some of that downstream to folks that have the ability to actually make the change.
Um, when you think about value-based care, I think the headline over the last 20 years is it's like it's coming, it's coming, it's coming, it's growing. Do you think we're going to see that accelerate, or do you see it sort of linearly expanding at the pace we've seen over the last 5 to 10?
I think, I mean, there's no secret that health plans, and we've seen the posts on LinkedIn and kind of in the news, that their goal is to shift everything to a delegation model. I think the majority of these national health plans are at like 70% total delegation. So I would say we're probably already there. What I would say is I think we do see a shift to more global risk arrangements. I think there's a lot of kind of upside or partial risk arrangements, or just a PCP cap. So not that full kind of global risk arrangement that I think these plans want to see. So I do think that starts to speed up. I think plans start to shift provider groups into a more global risk model, whether they're ready for it or not.
Do you think there's going to be less products out there? Do you think there's going to be consolidation there with under the umbrella of VBC? I mean, there's tons of different programs that come out both in the private side and in the public side. Do you see that condensing into like a winner? Like there's going to be one model that seems to really make it easy for people to participate in this?
I don't think there will be one, but I think there will be like 10 or 15, and I think it'll be regionalized. Um, I think historically, because of the margin opportunity with these plans, they were willing to have an experiment and have these like 5 to 10 year glide paths to global risk. I think because of these regulatory changes, that mindset has changed a little bit. So I think the goal now is to shift to global risk, and as fast as possible. And there's only a few organizations, and when I say a few, right, 10, 20 organizations that can do that at scale very well. So I do think we see a consolidation from that standpoint, and the speed there. I'm not exactly sure, but I do foresee in the next probably 5 years there being probably five, maybe 20 at most, consolidated super high level platforms that are doing global risk underneath these payers.
So, I mean, do you think that they're moving to full cap, given recent conditions, because they've come to the realization that there so much of this happens on the ground,
Right.
and really need is that the main driver of that? It's not necessarily regulatory changes that are really creating the friction. It's that, like, to make this work, you got to have boots on ground and really know those patients and those providers, have deep relationships there.
Yeah, absolutely. I think when you look at where some of these plans exist in the markets where they have a high penetration of global capitated risk, that's where the outcomes are best. So I think they've kind of probably run the calculus and have identified, okay, this is a model that seems to work for us, and I think they plan to expand that nationally and as fast as possible.
Yeah, that makes a ton of sense. So recently had an election, new administration coming in. Any thoughts on how that's going to impact value-based care broadly and Medicare Advantage specifically?
Honestly, I'm not sure. I think we've seen things happen underneath, both administrations, or both previous administrations. Obviously, we had the Inflation Reduction Act and V28 under this one, and then there was some of the CAPS and HOS, patient surveys that happened in the previous one. Um, I think generally the goal, on both parties, both sides, is to improve patient care. So I'm not. I think that one is a tough question. Full transparency, Brigham. I'm not quite sure. I think we may see some pullback to V28, but I'm also not. I, I'm not 100% sure either way on that one.
Yeah, I
I
guess
think
the way I
that's
think about it, it's more about the privatization of healthcare or aspects of it. The more you move into that side, the more Medicare Advantage and some of those plans, come into play. So I was just thinking it from that perspective, is deeper investments there on the private sector could fuel even more accelerated growth in MA, as an example.
well, and I think we've got kind of the ACO model and MA to compare side by side, and I think that experiment has probably not yet played out yet. I think there's material savings, right, on both sides of the equation. So I think time will tell. I don't know if we'll be able to see significant changes or have that determination in the next 4 years, personally.
Yeah, that'd be really interesting. Super appreciate it. I think might be time to open it to some questions if we have anybody in the audience who wants to dig in on a couple topics.
Yeah, let's dive in. So if you do have a question for either of our speakers, you can go ahead and drop that in now to the question module. And there's a place specifically for that that's different than the chat. And we do have a couple here that we'll get started with. And the first one is this. Uh, is there one thing we got right with VBC and need to double down on?
Yeah, I mean, I would say aligning incentives to outcomes. I think that makes a lot of sense. I think there's probably a lot of administrative burden that goes into some of the things that have been put in place in recent years. But generally speaking, I think aligning incentives to value is definitely the right move.
Yeah.
I'd love to follow that up with the flip of it, if I could, Logan. It's like, what did we get? What did we get wrong? What are a couple things that we could change from your perspective, really broadly speaking?
Well, I think the complexity of administering these value-based contracts, and ultimately, like, we're a since we operate both a staff and affiliate model, we have downstream participants within our risk arrangements. So administering those complex kind of risk arrangements downstream um, is difficult, and I think there ought to be a better way. And then I think from a data perspective, right, you get different data feeds from each of the 30 plans out there that do risk, and they're all different. And I think a consolidated view from both a clinical record perspective as well as the more structured kind of claims and MMR and MAO files, that is probably something that I wish personally, just because I spend a lot of my time digging into the data, was standardized when it came in.
Yeah, it's interesting. It's almost like more regulation there on how data is to be shared. More consistency is going to be required to make operators like yourself, have to focus less on data normalization and more on clinical care.
Yeah, I think when you spend kind of 5% or 5% of your total OpEx is lives with kind of just standardizing, normalizing, and getting information, getting data, there's something broken there, especially when all of the information flows from CMS in the same format.
Yeah, great. Next question here, and I may have asked these out of order here, is if there were one or two things that if you could wave a magic wand and change about how we've approached value-based care in the U.S., what would that be?
I think it would be the interoperability, like the data sharing, and probably the complexity of some of these contracts. There's so many different. I think these risk contracts. There's so many different concepts within each one. Some are tied to HEDIS and quality. Some are just a flat percentage of premium or an MLR. I think making things more straightforward. Um, I think that is probably something I would change. The data and ultimately administration of these contracts. I think it's become there's a lot of administration that goes into ultimately facilitating a risk a global risk arrangement and doing it well.
Well said, Logan.
And I have a question. How concerned should we be, kind of shifting gears to what's going on right now in Washington and the new administration? How concerned should we be either way that things are going to change for value-based care moving forward over the next few years, regardless of the administration in office?
I'm still not quite sure because I think we experienced changes to MA and value-based care in general from both administrations. I think right there's always talk about cuts to the Medicare fund, but I don't think we've seen that in the prior two administrations. And there's ultimately been changes, from a caps and HOS perspective, from a Inflation Reduction Act perspective, from a V28 perspective. I think it's too early to say. I really do.
One of the things that another question here that I had is I'm actually on the heels of the APG conference up in DC. In fact, I'm there right now, and one of the things that has come up in discussion is MA and how that is seemingly the future, and there seems to be a lot of buzz around MA. And the question arose is if we could again wave a magic wand and have by default everyone go into MA, would that be better for the Medicare beneficiaries or in general? What do you guys have any thoughts on that?
I would say I think a lot of because the whole concept of MA is having a narrow or a more narrow provider network to ultimately control downstream costs. I think a shift like that would be seismic. I think there's a lot of folks out there that enjoy the open access, and they like seeing the cardiologist or the pulmonologist that they want to see. I think there would be quite a bit of patient abrasion, if that were to take place. I think the ease into MA, where people get comfortable with the provider network associated with each plan, is probably the right direction. I don't I also think that there's probably some circumstances where, a straight Medicare plan with a Part D plan is a better alternative to MA. So I don't know if we want to limit patient choice here. I don't think that's the right move, personally.
Yeah, it's almost allow the patient to weigh the benefit of more choice, less benefit, versus maybe more benefits within the plan, but a little less choice on where to receive that care. Yeah, it's an interesting consumer behavior.
And there's something to be said for just simplicity of the plan itself and with the consumers. Which version of that do you think is a more simple, less complicated thing for the end consumer?
So I don't
I
know if
mean,
I
I,
can
I
answer.
don't I don't know if it comes down to simplicity, honestly, because I think when individuals turn 65, there's no shortage of information, right? They're meeting with brokers, they're understanding their options, and I don't think like healthcare is not simple here. I think it really comes down to consumer choice, and ultimately they're making informed. When I say them, Medicare eligibles, they're making informed decisions in terms of what's best for them, both economically and from a healthcare perspective. And I don't think it's right personally to take that choice away. I don't I would love for things to be that simple, but I don't think we sacrifice patient choice for simplicity's sake.
Okay. Yeah, no, that tracks kind of with the buzz. Another thing that comes up is CMS's continued push to have 100% of beneficiaries in a value-based care program by 2030. Do you think that this is viable given the trajectory of where we are at this point?
I think it's viable. I think we'll have to see some new entrants. I think like the MSO 2.0 needs to come to market. I think there's a lot of and we may have, it may already have. I think there's got to be a better way to ultimately pull all the information together and administer these contracts and do it with a patient centric perspective. Um, I also think there's probably areas and markets and regions of the United States where there's not a whole lot of, value-based penetration. So we'll have to see, some existing folks enter new markets or some new entrants enter those new markets, because I think certain states don't have because of the maybe the lack of appeal and the lack of MA penetration or VBC overall. Um, but in order to get there, we'll have to go into those states that currently don't have a deep VBC penetration.
Okay. Yeah, shifting gears a little bit to the technology side. What impact do you think AI is going to have that we're going to see over the next several years, specifically in regards to value-based care?
Yeah, I think when we talked about earlier driving a lot of our care models and stratification models, a lot of it has to do with disease discovery and understanding what's driving a patient's healthcare. Um, Sometimes, and Brigham, you can tell me better than and probably or explain it better than I can. The sheer amount of information um, drives providers crazy, right? If you were to pull, 65 years of a new Medicare eligible's medical history, it's going to take days to read it all. I think if there's a way to very quickly pull out the key findings and the important points to ultimately drive treatment, one, it shifts the time of kind of doing experimental treatments to figure out what's best suited for the member. But ultimately, it allows you to place the right care for the right patient as early as possible. So I think that to me is one of the more compelling points of AI. I think we're probably still a little bit a ways away. I think there's some hallucinations that still exist in these models. But if we're able to get to a point where we can trust the output of a summarization of 65 years of health history, I think there's inherent benefit there.
Yeah, I think the really interesting thing about the technology and its capabilities is its ability to, you know, build something for the individual. Like from a healthcare perspective, if I was going to take all that data and summarize the insight that mattered, and then share that same insight and make the same assumption with every PCP that I had access to, they all want something different. And I love the idea of providers interacting with the data, whether it's an insight as an outcome of it or another iteration of it, in sort of teaching their technology to say, this is what I'm interested in. I know somebody else might want to see that, but I want to see this and I want to see more of this. I think the ability for LLMs and in that area of technology to like evolve alongside a user as an individual is going to be really powerful for how we can give the right information at the right time to the right person in clinical care.
Yeah, I think that makes a lot of sense.
And some of what I was seeing too, again, and going back to this conference because I'm fresh off of it, is there was a lot of buzz around ambient listening and for help with dictation and taking again some of the effort off of the primary care physicians as they're interacting with their patients and across the board. And it apparently, it's still very much in the early stages, but what it can do to essentially summarize and give the cliff notes of a very long conversation and pick up specific things and make kind of a cliff notes version of that is pretty intriguing. However, all of these tools, regardless, still need the human touch. Someone to at the end of the day go back and monitor and make sure that it's not the hallucinations are not happening, and that there aren't key pieces of information being missed. But I do think harnessing that information alongside of the human connection, I think is really going to be a game changer.
And again, it's the same kind of power of the technology at this point, as scribes have been around for quite some time, and they would dictate notes based on this conversation in the same way for every user. And part of the feedback had always been like, though, that's not how I write my notes.
Right. Yeah.
With AI, you can actually, as the physician, teach your technology to do things the way you like them. And I think that's just an incredibly important part of care. And something that's been missing in healthcare is like we always look one size fits all, just because it's clinically the way to do it. It's not how everybody does it. And I love the idea of creating unique experiences for every provider at scale and at a cost that fits into the mindsets of how practices manage those things.
Yeah, very cool. A couple other audience questions here that have rolled in. Uh, how do you help manage plan attribution models to providers? We often find we are attributed patients that are seeing someone else and we've never seen.
So I think that is probably, I wish I could go back and say that's one of the more difficult things that I would change. What we've seen at physician care centers in terms of just a purely cost basis perspective, typically the folks that drive the most burden to the healthcare system, it's not the members that have these super complex conditions, like CHF and COPD and cancer diagnoses. It's actually the folks that aren't seeing our PCPs. So I think obviously that's not pure attribution, and that's not necessarily they're seeing another PCP, but they're attributed to us. But they're attributed to us, and they're not coming in for office visits. I think when we think about that, to us, it's probably the most important cohort to look at in terms of overall cost. We take a very aggressive approach there. So we send out like private investigator types to individuals to one, identify all the various contact for that member that exists through the TEFCA connections, but also through our any data that we have inside our EMR. We'll try all of the different addresses, all the different phone numbers, and ultimately we send individuals out to the patient's home to ultimately figure out, what's going on with the member, why they're not coming in to see us, if they understand who their designated PCP is, and then ultimately, if they are seeing another clinician, helping them transition to that individual, getting the plan on the phone, submitting forms. But it is probably one of the more difficult administrative things to accomplish within risk. It's a huge problem. I think it's typically like 5 to 10% of a population that's attributed to you is not actually coming in to see your PCPs.
Yeah, sure. And we definitely see that, especially in like the Florida and Texas market, where we have a lot of snowbirds that are spending a lot of time in different parts of the country. I know that that's continually an issue. Okay, next question here is how do you increase physician engagement as risk plan models increase?
So I think it's really important to have physician leadership within any organization, because I may have an idea about something, but in order to get large scale buy-in, I think providers and clinicians ultimately need to come to that determination themselves. So I think, in my perspective, having regional leadership driven by the medical committee is extremely important. When I have an idea, I present it to the medical committee, and it's almost like I'm back in junior high and presenting in front of my teachers. I let them grade me. I let them come up with their own determinations why it may or may not work. But I think once you have the medical committee buy-in, which consists of a representative population of your overall clinician base, I think it's a much easier conversation. And I fully agree that I think it's the clinicians that should drive everything clinical related. So I think as long as you can get buy-in from the folks that are making the clinical decisions, I think that's ultimately how you drive in behavior. Because it's impossible to drive down ideas without provider buy-in at the top level.
Yeah, indeed. Well, I think that is actually concludes our questions from the audience. And so we have got about 5 minutes to spare, so I'll probably go ahead and wrap up at this point. Logan, Brigham, thank you so much. This was a fantastic discussion, very intriguing. I know I got a lot out of it. I'm sure our audience did as well. And as we're closing out here, I wanted to encourage you all to head over to VBC Exhibit Hall and check out the virtual exhibit booth for Credo, and you can read up on them and what they're doing, and kind of dive into some more of their solutions and how they can help, and really educate yourself on them, and of course contact them through there. But if you would like to contact them directly, feel free to do so. Yeah, there we go. You can reach out to them and their information at info@credohealth.com, or feel free to reach out to me, and I'm happy to facilitate an introduction if that's easier for you. But thank you again all for attending today. Thank you, Logan. Thank you, Brigham. Hope you all have a fantastic rest of your day and join us on the next webinar. Have a great one.
Thanks for having me.
Bye bye.
Thanks, Garrett. Thanks, Logan.
Thank you.